everyone, in this video we will explain on the occupational therapy intervention for cervical myelopathy. And this is the content of this video. First of all, we look on the definition of cervical myelopathy. Cervical myelopathy is a condition describing a compression of the spinal cord at the cervical level of the spinal column. It resulting in spasticity, hyperreflexia, pathologic reflex, digit or hand clumsiness, and gait disturbance. The treatment is typically operative as the condition is progressive. This is the etiology of cervical myelopathy, where the ossification posterior longitudinal ligament (OPLL) is the most important and the main cause of the cervical myelopathy. For the incidence and prevalence, based on Nori et al. 2015, it states that it is estimated at a minimum of 41 and 605 per million in North America respectively due to degeneration of the spine. In general Japanese population, it is reported as 1.9% to 4.3% and up to 25% for patients with cervical myelopathy. And with an aging population, the number of patients presenting with cervical myelopathy is increasing worldwide.
Next is clinical features. The symptom of cervical myelopathy usually will develop slowly. Patients will experience neck symptoms such as pain at the neck stiffness, and also decreased cervical range of motion. Other than that, patient will feel numbness or tingling at the hand, clumsiness and poor coordination of the hand, weakness in the arm and hands, balance issue, and also gait disturbance. This is map of health condition according to ICF. Patients usually will have problem in body function such as muscle strength, dexterity, pain, and balance. So, patient will have limitation in self-care, hand and arm use, fine motor activity, and mobility. This also will affect participation in work, social life, and leisure. Environmental and personal factors are also interrelated to this cervical myelopathy. Frame of references that we use for this condition is biomechanical and rehabilitative frame of references. Biomechanical frame of references is considered as a remedial approach focusing on impairments that limit occupational performance. One of its goals is to compensate for loss of movement in occupational performance. Secondly, rehabilitative frame of references considers rehabilitation as the process of facilitating patients in fulfilling daily activity and social role with competence.
So, how this FOR can be used for cervical myelopathy? For biomechanical FOR, it used to address pain, strength, hand dexterity, and fine motor skills. While for rehabilitative FOR, it used occupation-based activity including IADLs and leisure activity. Now, we move to the intervention for cervical myelopathy. The first intervention is physical agent modalities or pumps that aims to reduce pain, numbness, and tingling at upper limb. It also aims to reduce stiffness at neck. For the fluid therapy, therapists need to make sure patients' forearms are free from the jewelry and clothes. If there is any open wound on skin, it needs to be covered first. Then start the fluid therapy with 38 to 48 degrees Celsius in 20 minutes. Therapists must be aware if patients complain of oversensitive on their skin. For TENS, therapists need to make sure patients' skin are dry and clear, and make sure the TENS turn off before you sit. Then put the patches on the neck region and start the treatment and change the intensity to strong but comfortable. This treatment can be done in 20 minutes. These are the other physical agent modalities that can be used for patients with cervical myelopathy. For the evidence base, Graham et al. On 2013 state that pain relief can be obtained through possible endophinergic mechanism of analgesia with the use of electrical muscle stimulation, TENS, or other forms of electrical nerve stimulation.
Second intervention is strengthening activity. This intervention is aimed to improve muscle strength of hand, to improve grip and pitch strength, and also to improve fine motor skill. The first activity is by using Therapeutic. For the procedure, firstly, take and place the Therapeutic into the palm, then press fingers through the Therapeutic. Next is release fingers and roll the Therapeutic to reshape and repeat the exercise. Grading for this activity is we can increase the resistance of Therapeutic gradually. Next, for the second strengthening activity is by using hand helper. The procedure is first, place the patient hand on the hand helper and ask them to grip the hand helper for 5 to 10 minutes and release. Then, ask them to repeat the step for 20 minutes. To grading this activity, we can increase the resistance of the hand helper. For the evidence base, according to Satya et al., resistive hand exercise such as a hand helper or gripper is to provide effective resistive therapy in a variety of exercises for the fingers, hand, wrist and forearm. With regular use, it will result in improvement of grip strength, increased dexterity and mobility.
The third intervention is hand dexterity activity that aims to promote good hand dexterity and to improve fine motor skills. The first one is pegboard activity. For the method, therapists prepare the pegboard set on table and ask the patient to put the peg on pegboard one by one until finish. Then ask the patient to pull back the peg until finish. For grading, this activity can be graded in terms of size of peg from big to small and size of peg hole from big to small as well. The second activity is taking coins. Therapists prepare the coins on table consists of 50 cent, 20 cent, 10 cent and 5 cent. Then ask the patient to stack the coins, start with 50 cent until finish. Therapists can educate the patient to try this activity at home. For the grading, this activity can be graded in terms of size of coins from big to small. For the evidence base, research by Omori et al. On 2018 state that cervical myelopathy caused by spinal cord compression can lead to reduced hand dexterity. They also state that patients with cervical myelopathy have difficulty in manipulating relatively small objects with their fingers during activities of daily living, in which fine motor control of the fingers via various sensory feedback mechanisms is necessary. The last intervention is occupation-based activity for balance and coordination. The aims of this intervention is to promote good body balance while sitting, standing and walking. It also to prevent from risk of fall. The first one is dynamic balance during RADLs. Therapists can educate patients to making bed in standing position, including stripping the sheets and putting on clean sheets for an extra challenge. Therapists also can educate patients to do dusting on lower and high surface. For the grading, this activity can be done from sitting to standing position. The second one is recreational activity. Patients can play table tennis as it is fun occupation-based balance challenge. They also can play cornhole, which involve functional reaching and core control. For grading, this activity can be graded by increasing the duration in performing the activity. For the evidence base, based on OTPF 4th edition, intervention implementation must always reflect the occupational therapy scope of practice. Occupational practitioners should not perform intervention that do not use purposeful and occupation-based approaches.
For the conclusion, cervical myelopathy is a common degenerative condition that will result in clumsiness of the hand and gait imbalance. So, occupational therapy will play an important role in treating patients with cervical myelopathy that aim to reduce the pain, increase the strength and also promote good body balance. Therefore, the patient will be able to perform activity of daily life, work and participate in leisure activity. That's all from us. Thank you for watching.